I'm having a few. Oh, perfect. Hi, everyone. Welcome to our multi-heart lecture series. It's a pleasure to have Dr. Susana Prat Gonzalez today with us. She will be talking about cardiac magnetic resonance and the use of 4D flow technique. Dr. Susana Prat works at the hospital clinic in Barcelona, a place that is world-renowned for the imaging capabilities. She trained in Barcelona for her residency fellowship and then worked for 2 years at Mount Sinai in New York. And now she's back there. She has published extensively in cardiac imaging and valvular heart disease. Thank you so much for joining us, Susana.
Okay, thank you so much for this nice introduction. First, I need to say that I'm very happy to share this talk with you, especially because when I was in Mount Sinai, Dr. Mario Garcia was my boss, an excellent boss and my mentor, and I have a very good memories of that time. And it's a pleasure to give this talk to you. Okay, let's start. I don't have conflicts of interest. And to start with the topic, I want to introduce the role of cardiac MRI with our cardiac patients. We know the cardiac MRI technique is a good one to study the anatomy of our patients with sequence with angio-MRA, that the morphological sequence spin echo. We know that is the gold standard for the ventricular volumes calculation and ejection fraction with cine images. That we know that we can study ischemia with perfusion sequence and stressors as regadenoson or adenosine. As well, we can study the edema, myocardial edema with patients suspected of myocarditis or like acute infarction. As well, now we have the parametric T2 maps to study this edema. And as well, we know that is the non-invasive technique to analyze the fibrosis and the size of the infarction with the latent Hussman 2D and 3D sequences. As well, we have as well the analysis of the interstitial fibrosis with T1 maps. But as well, we can study the flows of the valves and of the vessels of the heart and the thoracic structures with the sequence of flow. As we'll see, we have the 2D phase contrast by MRI and recently the 4D flow sequence. To introduce the flow analysis by MRI, we need to say that the gold standard sequence for this is the 2D phase contrast, that is a technique for cardiovascular flow quantification by MRI. How we use this sequence? We get two images. One is the morphological magnitude image, that the vessel that we want to scan. We need to scan usually in a perpendicular plane. And we get another image that are the velocity and cone map velocities in one direction that we can see in a gray scale. These velocities are in plane or through plane. For this sequence, we need to establish a parameter called VEN, that is the velocity encode, that needs to be controlled for our operator or technologies, and is the parameter for the maximum velocity expected to avoid aliasing. And this parameter, it's very important in this sequence because we need to establish before to scan. These sequences are short. Usually we use a breath hold, but needs time and supervision to be planned because, as I said, we need to select well the vessel or the valve that we want to scan and do a two perpendicular axis to get these images. With these images, we can get the flow curves, because if we have a method that we can analyze the area through the cardiac cycle, as we see here, times velocity, from these images we can get the velocities, we can have this nice course of flow, the systolic flow, as we can see here, and the diastolic flow, that here is a aortic regurgitation with a regurgitation fraction of 24, and it gives this information for this flow. If we have a patient with complex flows, we'll need multiple acquisitions. For this, these two sequences are time-consuming. Recently, we had this 4D flow PCI sequence that is an extension of the phase contrast PCI MRI. And in this case, the velocity encode is in all three spatial directions along the cardiac cycle. For this, we have the three directions of the spatial directions plus time 4D. We acquire a volume, as we'll see. We can get a lot of flow, all the information through all the vessels. Is one acquisition, and the data analysis is done retrospectively. The 4D flow has been validated against the 2D PCR MRI, as they show in several studies, and the 4D flow has shown a good intra and inter-observer variability. And here we have an example of how it works, similar than the 2D. Once we get, we choose the vessel that we want to analyze, with these for example, two axes, we get this cross-sectional, and with the dedicated software, we trace the area through the cardiac cycle, and the software, it gives us all the information, the quantitative information, as we'll see. Already in 2015, the scientist imaging community published this consensus statement about how to perform the 4D flow, the specification, and the indication. Later on, in 2019, as well, the group of the expert on congenital heart disease did a recommendation of this sequence, especially in this subgroup of patients, with all the indications and all the specifications. And recently, there's this new and good review about the role of 4D flow in clinical intracardiac flows study. All of this, it shows that there are a lot of interest, people that were dedicating our studies in cardiac MRI, that this can be a good sequence for some of our patients. And that this technology is already here, and the idea of this talk is do a practical overview that how it can help to us. But first, I need to establish some technical issues. How do we acquire this sequence? We use, I will explain our experience with this 4D flow. We use a 3 Teslas MRI G scan. And this is the screen that our technologies planned of our patients. Here we can see that we acquire a big volume in of the thorax. We include a lot of vessels and structure. That we use the axial acquisition, and our sequence is a free breathing sequence. But there are other groups that they use the respiratory navigator to acquire this sequence. The important thing is to get a good spatial resolution that in our case is a voxel of 1.4 per 2.2 millimeters. That is a quite good spatial resolution. And the other parameter that needs to be good is the temporal resolution. We recommend, the guidelines recommend less than 50 milliseconds. The acquisition times depend on the breathing and the heart rate. And usually with this sequence, in our example, it lasts between 5 and 10 minutes. In our center, we use a slow infusion of a small bolus of gadolinium contrast, because this increases the signal-to-noise ratio. And as I said before, for the 4D flow or for the flow PC MRI, we need to establish the bend. That is this maximum velocity that we expect. I write here to 200 centimeters per second, but because maybe if we get all the studies that we are performing, this will be the average. But of course, if we are scanning a stenosis, maybe we need to go down, up of this 10. And it depends, if we are in Fontan patients, maybe we need to go down to these velocities. Once we do the acquisition, this is a scheme where it shows first the acquisition data from the scan. And there's another step that it's important, that because we have to correct this, we do these correction errors that, for example, this is more technical, that there's eddy currents, aliasing artifacts, and all of this. There's a step that we call pre-processing phase offset correction that are done usually in the same software. And when all of this is done, we are prepared to get a huge amount of data. We need to say, usually for the flow is a lot of data that we transfer to a specific software dedicated for the data analysis. The post-processing part in this sequence, it's very important. And how we analyze? First, we have the flow visualization in 3D. And what we can get? We get images, anatomical images, similar than we can get from the MRA, similar than MRA. We see here the heart, the vessels, and in a gray scale. But we can get the velocity maximum intensity projection that are a color map velocities that we can get images in Cine that flows with a high velocity are red and flows with a less velocities or like low velocities are blue. And with this, you have a good visualization that was going on with these vessels and the flows. There's another flow visualization that are the streamlines that are they represent the instantaneous local vectors along the length of the flow that you can see here. It led us to see if the flow is laminar or if it's helicoidal, and it's a good representation of this flow. And as well, we have the velocity vectors that are narrows that represent speed and direction of the flow velocities. As I don't know if you can see, but you can see these vectors with high velocities because they are red, and all of this is done by a dedicated software. And it's like an image that it gives you a lot of information. That was the visualization, but one of the important tools that we have with the 4D flow is that it led us to do a flow quantification and evaluate the hemodynamics of these vessels or valves. We can get information about the forward flow, the reverse flow, the peak velocities that we can get as well from echo. And another concept that is important in some pathologies, that is the regurgitation fraction. And we can get this curve. As I showed you before, we get this in the pulmonary valve, we get this image, we proceed, and we have all these quantitative parameters. And at the end, we have this flow curve that is systolic curve and diastolic reverse flow that you can see almost is 50 of the systolic. For this, the automatic calculation of the regurgitation fraction of this patient is 51. This is an example of a tetralogy of Fallot with a severe pulmonary regurgitation. But a part of the visualization and the more normal or usual parameters for quantification, the 4D flow, it has an interest in the field of I said the medical engineer. I'm not an engineer. I'm a clinical, mind, and I don't want to be. I don't want to say anything wrong about this, but I want to show that this part of the 4D flow is very important because we have advanced hemodynamic parameters that they need a lot of support of bioengineers, but they help us, and as we'll see, to understand some pathologies and the physiopathology of them. And here, I show, in this review that I like, I only want to show this this wall shear stress that maybe will be the one that someone knows about it. That if we see that this is the thoracic, the vessel wall, the red line, we can have that we know that the blood flow induces mechanical forces on the vessel wall tangential. That is, and this concept is wall shear stress as well. And we'll see that in some pathologies that is quite interesting to study. There's another parameters, the new advanced parameters like turbulent kinetic energy, viscous energy loss, vorticity, and it's not. This will be only a topic, a special topic, but I will not be the one to explain. And to be more practical, I divide the clinical part of the 4D flow in four categories. First, we'll start with the aortic disease, in which clinical scenarios we think that it can help to have a 4D flow analysis. I want to mention about the aortic disease. One of the groups of patients that are well studied by 4D flow is the group of bicuspid aortic valve. We know that these patients, usually at 80% of them, they have a dilated aortic dilatation. In Barcelona, we have this group from Vall d'Hebron, Dr. Evangelista, Dr. Rodríguez Palomares, that they are studied for a long time, a huge amount of patients with aortic disease, bicuspid, Marfan, or dissection, and they have several publications about the role of 4D flow in this scenario. And I want to show this paper because I thought that was interesting, that a part of the genetic part of the wall of this patient, that the aortic wall has some genetic problems, and this can justify the dilatation. We know that the flow dynamics of these patients can have some part on this dilatation. And this was shown that they divided the bicuspid phenotype, and they show by 4D flow that the right-left phenotype bicuspid valve patients was associated with higher right anterior wall shear stress that we can see here. The wall shear stress in these patients with this phenotype, they have more wall shear stress here in the anterior wall, and this was the part that was more dilated in these patients. But in the group of the other phenotype of the right and non-coronary cusp bicuspid valve, they show that the wall shear stress was higher at the posterior wall first, and later in the anterior distal to the aorta, as we can see in the second example. And this can have in the future some prognostic importance, and I wanted to show this nice work and how these new parameters can help in this bicuspid patients studies by 4D flow. Following this example, I want to show you a case of our center that with the help of a past fellow that now is in Chile. This was a 60 years old male that had a moderate aortic regurgitation, that in echo they saw that the aortic valve was not normal. Here we have a short axis view by MRI of the aortic valve. We can see the three cusps. One of them is hypoplastic, and the opening is bicuspid, typical of a bicuspid valve. He had a dilated aorta, and we did our protocol of aorta, bicuspid valve, and we did our 4D flow. And here I want to show you that we can see that the flow had this direction with high speed, and when we apply the software for the wall shear stress, we could see that the wall shear stress was higher at that part of the anterior wall of the aorta, and we can see here, and was the part that was dilated. This is an example of our daily practice, and this patient we know that needs to be followed, and maybe this will be a good technology for this follow. Another case of our center was a 62-year-old male that had history of hypertension and sent to us for aortic coartation study. Apart, the patient had another thing, that if we focus here in this 3 chambers view of cine images, we can see that the aortic valve has a reduced opening and asymmetric opening. And when we plan the cine short axis view of this aortic valve, we can see that the opening is reduced, and there's this right and left bicuspid phenotype. The patient had aortic stenosis, and we perform as well an angiography, MRA, that we can see that if we apply the 4D flow as well, we can that let us to measure different flows at different levels in the aortic coartation. Usually we go here, we go before the coartation, after the coartation. But the thing that I want to show you, that is this patient, the 4D flow show first these nice images that if we focus first here, we can see that there's the intercostal arteries very prominent. And if we focus in the zoom, we can see that usually in our experience, we don't see these arteries. And as well, if we go to the 4D flow of this patient, we can see these prominent mammary arteries, both of them. Usually you don't see. And this is the clue. This patient has a significant aortic coartation with a hemodynamically significant. And with these nice images, in fact, you don't need gradients, or like, you know that this aortic coartation is significant. But if someone asks me about the 4D flow right now, I will tell them that for me, one of the scenarios where the 4D flow can help more is in the congenital heart disease patients. I need to say that in our hospital, we don't treat children. We have adult congenital heart patients that they come when they arrive to the adulthood, they come. Usually they come with several surgeries. Sometimes you know, sometimes you don't know what was the procedure, or like, and as you can imagine, the echocardio is the first line to go, but the 4D flow and the cardiac MRI is one of the techniques that it help us to do the diagnosis. And as I said, I try to do some cases to show this. And why 4D flow it can help in these scenarios? Because it let us the visualization of and evaluation of abnormal flow patterns in these complex patients. It let us the shunt calculation that is important hemodynamically in some of these patients. It let the direct assessment of the valve function, and as well the new flow dynamics parameters as wall shear stress, kinetic energy, can help us to understand the physiopathology of them. And here we'll continue with a case of our practice that was a 50-year-old female that came to ER with a ventricular tachycardia. She said that she had 3 previous cardiac surgeries, and we could see thoracic wall deformation. For this reason, she had a poor echocardiographic acoustic window. As we can see here is an example, one is a loop of the echocardio. We could see that at the level of the pulmonary valve was an accelerated flow, and we suspected that she had a pulmonary valve stenosis. we went to the cardiac MRI study. And if we think the way that we should study this tetralogy of Fallot patient, with 2D phase contrast sequence, first we'll need a flow in the pulmonary artery, second in the aorta, as well in the left pulmonary artery and in the right. It means we need to plan for at least 4 sequences, well planned, that with perpendicular to the vessel in its times and a good technologies, and to be there maybe to supervise. For this, we have the 4D flow, and in this case, we, as I said, we got all the volumes, and we got the pulmonary vessels, the aorta, all the valves. If we see this velocity map, we can see that in the area of the pulmonary valve, we see these high velocities in systole, and we can see as well a reverse flow of pulmonary regurgitation. We plan our software, the area along the cardiac cycle, and this patient we confirm that had severe stenosis and significant pulmonary regurgitation. But as well, when we did the 4D flow, as you have a volume, you can reconstruct as you want. Here we have the the short axis view. This is the left ventricle, this is the right ventricle. And when we were looking to the 4D flow, we saw a jet that it came to us, and we put the reference line, and we could see that this jet was a left to right shunt that was a residual ventricular septal defect that was missed by echocardiography, and was missing the other sequence as well of MRI. And this, in this case, we had all this information in the 4D flow. The patient went to surgery and went well, and all this information was transferred to the cardiac surgeon. Another example of left and right shunt is the patient that came to us, 69 years old male with severe aortic stenosis, and they asked for a pre-surgery cardiac MRI. Here, the 3 chambers view, we can see that the left ventricle is moving well, and here in the aortic valve, we see that the opening is reduced. And this is the 4 chambers view, cine 4 chambers. We can see the left ventricle, some dilated atria. And if we focus in the right ventricle, that is moving quite well, but we see that it looks at least mildly dilated. This case was presented by Dr. Daniel Lorenzati, that I guess that almost all of you know, that was a fellow with us, and thanks for this nice preparation of the case. We did our protocol of the aorta. The angio was normal, and we planned our 4D flow. Here we calculate the stroke volume in the aorta, that with the 4D flow, calculating a QS normal. We did the same for the pulmonary trunk. We calculate the flow at that level, and we calculate the QP. And we saw that the QP-QS was significant, was 2, that was a significant shunt left to right. But where was that shunt? If we go to the short axis cine, we can see here the left atria. Here we have the right atria, and this is the way where the coronary sinus go to the right atria. But if we focus here, we can see that there's some problem, that the roof of this coronary sinus seems to be disrupted. But if we move to the 4D flow, we have the confirmation that we have flow going from the left atria through the roof of the coronary sinus to the right atria. And this is a rare case of unroofed coronary sinus that show in this picture, that was that the patient had, apart plus the aortic stenosis. This information was very important to for the surgeon because could solve the both problems. And this was suspected by the 4D flow and all the measurements, quantitative and visualization. In the field of the congenital heart disease, I think the new parameters are very important in some groups that they are especially complicated because the hemodynamics and the physiopathology is very complicated, as the Fontan circulation in these patients. Here, I want to show this nice work from the group of Leiden that they show that abnormal conduits geometry and flow patterns presented more energy loss. That the energy lost is the kinetic energy that is lost due to frictional forces in the flow. It means usually you have the conduit and the inferior vena cava junction, that they show that some patients have here more energy loss that we can see here in red. And they conclude that the IV junction mismatch is a potential source for energy loss at this level. Depending on the geometry, this can be higher or not. And this mismatch, this energy loss, it could explain the lack of exercise capacity that usually they have, these patients, and as well the increase of venous pressure, cirrhosis. And this is a line that I think that can help with flow dynamics studies to understand this complex physiopathology. Continue with the valvular disease. I want to show a case that of the direct valvular evaluation. If we focus here first in the cine 4 chambers view, we can see that the left ventricle is moving okay, it's not dilated. It has this funny movement in the basal septum, inferior septum, and we see that the right ventricle is dilated and the right atrial as well. And if we go more carefully, we see that the septal leaflet of the tricuspid valve is more apical than should be. If we go to the 4D flow with the color map visualization, we can see that there's a systolic flow that starts in the middle of the ventricle, at the level of that. It means that this tricuspid valve is more apical, and we can see that this huge flow, systolic flow through the atria. This is a good example of Epstein disease patient with this severe tricuspid regurgitation with this eccentric jet. And as well, we can see there's a right ventricle lateralization. Only with one picture, with one image, you can get all this information for the 4D flow. Continue with the valve analysis. There's a lot of interest because, and this was done by a fellow of us that came back to his country, to Chile, and they are studying this interesting valve tracking. That there are a lot of interest because with 4D flow you get the information for the 4 valves at the same time. We need for this valve tracking, we need to have at least some thin images. And the idea is instead of doing this manually, that we need a lot of frames to analyze one by one, there's a dedicated software that now they can follow and do the automatic valve tracking. And in this case, you can see here in systole that there's this eccentric flow of the mitral regurgitation. And when they applied the 4D flow images, they could study the diastolic flow and the systolic eccentric flow of the mitral valve. As well, we can, as I told, that the idea is that with 4D flow, we can study the 4 flows through the valve, the pulmonary valve, the aortic valve, the tricuspid and pulmonary. as well. That and in this line, I want to show you this study that I consider that is the way that in the future maybe will go, because they show that in a multi-center study that that they use different scans, of different vendors with different magnetic fields, with different 4D flow sequence and contrast agents. And they show in this multicentric study that there were a good inter-observer correlation with the valvular flows for all sites and valves. At the intervalvular and inter-observer variations were low. And to do this automatic tracking of the valve, they recommend that instead of one cine image per valve was better to have 2 cine views for each valve, as we can see in this picture, that to analyze the mitral and the tricuspid valve, they use the 4 chambers and the 2 chambers right or left view. And they conclude that performance of automatic retrospective valve tracking was comparable for different degrees of valvular dysfunction. It must to say that if you read this paper at the end, one of the limitations is that it's true they had a nice results of the 4 valves in different sites, but the degree of valvular dysfunction was not so severe. And the other limitation that they point out that is this was not done in congenital heart patients, that maybe it will be interested to reproduce, because it's one of the subgroups of patients that they can have several problems at several levels. And to be finishing, I will mention only a few things about the analysis of the intracardiac flow. I recommend really the paper, the review that I mentioned. But in our group, we're collaborating with some medical engineers from the university, and we have a big group of atrial fibrillation ablation, and we are working a lot with cardiac MRI and with cardiac in the terms of fibrosis and pre and post ablation. And I consider to explain that one of the role of 4D flow in the intracardiac flows will be at the level of the atria. Why? Because if we can get a detailed evaluation of the flow in the atria, may help us to understand the mechanism of thrombus formation. That is an important clinical issue. That it's postulated that the formation of vortices within the atria may have a role in avoiding atrial blood flow estasis. And I understand this like if you have an atria with a lot of vortices, is that this flow that goes around, that is moving. If you have a lot of vortices, I can understand that maybe this will avoid this slow and anesthesis flow, and this will avoid the thrombus formation. If you can analyze these vortices in the atria, you can divide the patients, and they show in other studies that the young patients with non-disease, they have more vortices than patients with atrial fibrillation. And another larger study, including 40 patients, revealed that the LA blood flow velocities are reduced in patients with paroxysmal atrial fibrillation. These velocities calculated by 4D flow are lower in this patient, that it makes sense if you compare with patients without atrial fibrillation, with healthy subjects. That all these flow dynamics can help us in this in the atria to predict events. And I want to show that that example is a case of our center that share our colleague from the medical engineer group, that we can see that the pulmonary veins, and this is the left atrial appendage, how they represent with our data all these vectors and vortices, and we don't have this is an example, but we don't have yet the whole analysis of all the patients that we did. But hopefully in few months we can get some information. And to conclude, I would like to say that 4D flow is a good alternative to the PC flow analysis in complex heart disease patients, because in one single acquisition scan, we do visualization of abnormal flow patterns, shunt calculation, and direct assessment of the valve function. That new hemodynamics parameters as well shear stress and or energy loss can help us to understand complex hemodynamics patients and physiopathology and to predict events. And however, more clinical and research studies are needed to confirm the real clinical value of 4D flow in these groups of patients. And of course, I want to thank the audience and the group of cardiac MRI, that we are radiologists and cardiologists working together, our fellows, the past and the present, that without them, that the work will be very hard, technologies and all the administrative and nurses, that all the group of people that let us, that this is what the science goes and the patients had a good care. And thank you so much.
Thank you so much, Susana. That was an amazing lecture and such a promising technique. So please put your questions in the QA, and maybe Dr. Garcia, would you like to start with the first question?
Susana, that was amazing. That was fantastic. And it's funny because I was thinking about ideas, and as I was thinking of them, you were already on the next slide presenting them. So I am behind. But I had a couple questions for you. Because it's hard to tell because of the slow transmission of the moving images, to get an idea of what is the temporal resolution that you get in 4D. How many potential data points per cardiac cycle you can get over time?
I don't know if I understand the question. The temporal resolution that we get
right.
at minimum is 50 milliseconds. Like it's less than this. That of course is not, but we recommend less than 50 milliseconds the temporal resolution for the acquisition. Is the
right? I suppose that the way that you can vary your temporal resolution is prolonging the length of the acquisition, no, taking more data from multiple.
Well, they are as well all that this algorithm of compress sense and all of this. That's there are a line, that they are doing a lot of research how to improve this. And there's a different algorithm. We average repetitions and assets, but it's a very technical part. But there are a lot of interest and the compress sensing. I think enters in this this algorithm to increase.
Do you compare to the phase contrast? Does it take more time, less time to do the study in terms of acquisition time?
The acquisition time is a simple 2D, for example, QPQS or like aortic regurgitation. The 2D is the gold standard at that moment, and is one slice. You can do the pulmonary artery, or you can do 2 slices, and these are 30 seconds. But and the 4D flow, let's to be real, that it means an average of between 7-10 minutes, 7, or it depends on the volume. Acquisition, it depends on the patient, is longer by 4D flow. But in complex patients, if you get a good 4D flow, you can get all the information. And I think, for example, I don't treat children, or I don't scan children, but I think it's one of the focus, because if in one children you need to sedate the child and in one scan, in one sequence, you get morphological and flow information, I think if this is improving, I think will be the target because you could analyze without radiation a lot of hemodynamics values. Right now, the 2D in an aortic patient is shorter because it's one breath hole for image. The problem is that you need to plan very well. You need to be very perpendicular to the flow. That the eccentric flows are difficult for 2D PC MRI, and this is solved by 4D flow. At the end, there's a balance between the time that you need to do a good 2D PC. I don't know if or like you got all the volume with the condition, and after post-process you check your 4D flow, and you do, okay, the flow it's more eccentric. I do the analysis at this level. I go more close to the valve because there's some vorticity. The vorticity, it can underestimate the flow. You know, you have more possibilities. At the end, if you get a good 4D flow, I think it will be the way to go.
So in other words, if you have someone with multiple valve problems, probably the 4D save you time. If you're only evaluating the mitral valve or the aortic valve, maybe 2D will be shorter. I get it.
That multiple, if you have multiple valves problem like stenosis and regurgitation that is a problem. There was a lot of interest in the multi-bank that to put in the same sequence banks like velocities and code high and low. But it seems that at the end, as I read, because only we get one, we decide which is the most important, and we plan the bank for this. But there's some groups that they short the volume and they choose, and they do 5 minutes with different velocity and code. That's there's another strategy. It depends on what you want to analyze.
Thank you very much. We had some questions from your prior fellows that Daniel and Julian, that they asked about this dual bank.
The dual.
They asked about this dual bank, or how do you select the bank? Do you use the echo data, or is?
Yes, fortunately, all the patients, they come with an echo previous to the cardiac MRI, and we try to answer the question. But usually are more for the regurgitation fraction, for the systole, for the peak velocities as well. If you have a good echocardio and your aortic stenosis, or it's true that there's evidence that if in eccentric jets, the 4D flow is quite good for the peak velocities. But in our daily practice, the stenosis for the aortic stenosis we don't need. For pulmonary stenosis, for example, or double lesions. We need to choose. There's this algorithm as well in the post-processing, that anti-aliasing algorithm, because we know that if we go short with the velocity encode, this is a very technical, I know maybe will be boring for the audience, but if you choose a velocity that is lower than your high velocity, you can get these aliasing artifacts, but they have already some algorithm to avoid this. And if you are between the two, you can choose like an average bank. But if not, you decide which is more important. And usually for this, I put 200 centimeters per second, because if we analyze the whole number of 4D flows that we did in these last 4 years, maybe this will be the average of velocities that we choose. It helps for the aorta, it helps for the pulmonary artery as well.
Thank you very much. And so moving, you talked about the 4D flow in the atrium. What about the ventricle? I know there's some research being used for cardiomyopathy or maybe HCM. Do you see any potential use for this?
We are acquiring the data. We are acquiring. It's true that, but so far it's more that these new parameters, no, that the dynamics, no, the flow dynamics. I don't have real data. Is that the thing that I read? We are acquiring, but we are not analyzing yet these parameters, because as well we need this important collaboration with medical engineers. You know, because a part of the segmentation, we need to what represent the data that you are seeing, that and because there are a lot of maths, you know, that a lot of numbers, and fortunately we are studying the hypertrophic cardiomyopathy patients, but and hopefully we'll have data in the few, let's say, years, in the next years. But there are a lot of interest in the ventricle as well. But in terms more of the hemodynamics parameters advanced, like the vorticities and all of these, but and energy loss, you know, in the ventricle, but all of these concepts.
Thank you very much. There's a question from Luis Serna, one of our fellows, and what are the factors that limit this technology for being applied? Do you think it's a processing of all the technology? Do you think machine learning or AI can help us process this faster? Yeah,
that's for sure. That I cannot say now that the artificial intelligence doesn't have. In this case, that you work with a lot of data, that for sure that it will reduce timing and information. That's for sure. And I think they are already this dedicated software. They have a lot of interest, and always you have the update. Oh, we have we improve our artificial intelligence algorithm. Always you are. I don't know if you have this feeling that every 6 months they have the update with this new algorithm, and it goes faster. No, if you, in your experience, you do the volumes much faster, much better. That no, for sure. That and in the 4D flow as well.
What about, so we have another question. What about using 4D flow as a therapeutic target, or to measure a therapeutic success, even for Rob Osfeld is asking about exercise or lifestyle interventions, but what about also pharmaceutical? Do you think it could be an outcome for the flow? It could be used as an outcome of therapies?
Sorry, I don't understand. In which context? Sorry, I don't know if I understand well.
If you could use as a target, for example, as a measurement, if you do healthy lifestyle or better exercise interventions, do you expect that you could measure with 4D flow improvements in hemodynamics, maybe with 4D flow in the ventricle? Or
I guess that all the information, for example, I'm thinking, I don't know if for example, if the hypertensive patients, you know, that the hemodynamics that you can get from the aorta, if you change you control weight, blood pressure with exercise, I guess that it can. It's not right now the patients that we are scanning. As I said, we focus right now in the congenital adult patients, aortic patients, some valve with valve pathology. But I guess that if some sequence, it gives you some hemodynamic data, and you change, it's like the echo. No, I don't know if I answer the question.
Yeah, no,
maybe you can help me. You can help me.
No, that's perfect. And we have a very good question from Edwin Ho. He asks about post-intervention using 4D flow for prosthetic valves or post-mitral clip, for example.
Yeah, we don't. No, I know that there's interest in this. I don't have experience, but I think it's feasible, because the problem is the artifacts of the the image. I don't have experience. I guess that metal is the big enemy, in cardiac MRI, in all the levels. I guess that for mitral clip, I will not be in terms of the analysis of the flow there. If you the other thing is that in indirect flow, or the ventricle, the remodulation of the ventricle, and the flow in the ventricle or the atria, specifically where there's metal, the flows is compromised. But indirectly we can measure the ventricles and the flows. But I don't have experience with these patients.
Okay, thank you very much. That was wonderful. And we're hoping to see your newest papers when you have all this data processed and acquired.
And hopefully I can come to visit you again. That it was a pleasure. And if you come to Barcelona, say hello, and we'll show you the hospital clinic. But okay.
Will. Thank you very much.
Thank you, Susana. Thank you.
Okay. Thank you to you.